Okay, I guess we'll get started now. So it is my pleasure to welcome you to this Scientific Cafe and this event today. And we really appreciate you coming, taking your time and your interest in this particular topic. So before really starting off things, I would like to acknowledge that UBC Okanagan and Interior Health, who are sponsors of this event, are situated in the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. And we would also like to acknowledge some of you may be joining us today from many places. Some of you may have traveled, some of us have traveled from a distance, near and far, and we acknowledge the traditional owners and the caretakers of those lands. So, just to introduce myself, I'm Kathy Rush, and I'm a professor in the School of Nursing at UBC Okanagan. I've been there quite a long time, I guess about 16 years, and supporting people living with atrial fibrillation sort of has been my passion. And so I've been doing research in this area probably for about 10 years, and also have had the privilege of working with many of these folks, and also graduate students who are interested in that topic. So I would also like to acknowledge the funders for this event, the Canadian Institutes of Health Research and the Michael Smith Health Research BC. And this event is also supported by the 10th Annual Okanagan Embrace Aging Month, which was launched 10 years ago, so it's celebrating its 10th anniversary, to celebrate and raise awareness about positive aging, and has once again organized a number of educational opportunities and events during the month of March. So the sessions are designed for everyone, the Embrace Aging sessions, young and old alike, and they focus on a variety of topics related to healthy aging and ways to improve quality of life among seniors and their family caregivers. And the goal is to inspire everyone to embrace positive aging. So the focus of this Scientific Cafe really is on self-care to enhance living your best atrial fibrillation life. And our expert panel will be bringing different perspectives about self-care and atrial fibrillation, and I will introduce them shortly, but clinical perspectives, research perspectives, and personal perspectives as well. And we hope to hear from you as well, even from your personal perspectives. But before introducing the panel, I would like to describe the aims and the ground rules of the event. So each of our panel experts will talk for about 10 minutes. And while they are speaking, you can take notes, you can maybe jot down some questions on the sheets of paper that are there on your table. And then after each of the panel members has had an opportunity to speak, we'll then have a short 10-minute break. And then we will reconvene, and that will be your opportunity then to ask all of your questions. And before, we will also be using a microphone so that you can ask your questions and everyone can hear them. So before closing at about 7 o'clock, I will go back then and ask each of our panelists to do just a basic wrap-up, their kind of closing thoughts before we finish off. We also have provided evaluation forms that we would really appreciate your feedback on, and those are also at your table, so do feel free to complete those. And we will also be taking a few pictures of the event tonight, so if you don't want to be really included in any of the pictures, you should just let us know before you leave. So, without further ado, I would now like to introduce our panelists in order of their speaking. So to my immediate right is Dr. Kevin Pistawka. Many of you may know him. I have to get my notes out here, Kevin. So he is a cardiologist and has spent most of his cardiology life in Kelowna, but he certainly has been in Ottawa, did some of his medical school in Vancouver, was also in New Zealand for a period of time, and he has done a lot of really fascinating things. He is an associate professor at UBC Okanagan. He also is the co-medical director of the Central Okanagan Association of Cardiac Health. And some of you, as you probably are aware, it's called COACH, and maybe have access services there as well. He is also, or used to be, I guess, the lead of the medical student and family practice residency. And I probably could, and I also wanted to just say, he might not want to brag about it himself, but I did notice that he is actually one of the top-rated 3 cardiologists in Kelowna. So I needed to just put that little plug in. But he is also, he's married with 4 children, and he is, there was something else. Oh yeah, and he's also an avid sportsman. He likes lots of sports, skiing, and many, many things that he can tell you about. And then to Kevin's right is Cheryl Sargent, and Cheryl is our patient panel member, 64 years old, who has had AFib for about 4 years, but she will tell you much more about her journey. She is a semi-retired Masters of Social Work, social worker, and she actually did her master's degree at UBC Okanagan, so she has affiliations there. But she has 3 adult children and 2 granddaughters, and she was originally from Manitoba and relocated here in the late 1980s. And she is a patient partner, and she has been working with Dr. Peter Lewin as well as a patient partner, contributing to research. And I want to put a plug in that if any of you are interested in being a research partner, to please talk to us. And Cheryl can probably share some what that role is like and has been like for her. Dr. Ryan Wilson, who is on Cheryl's right. He's been a registered nurse for 21 years and worked at Kelowna General Hospital in the emergency department, where he developed a keen interest in cardiovascular care and specifically atrial fibrillation. And he's been with UBC Okanagan School of Nursing for the last 15 years, and his research is focused on this topic of self-care, both in trying to enhance patients' self-care before diagnosis as well as after their diagnosis. Let's see. And finally, last but not least, Dr. Peter Lewin is a pharmacist and associate professor of pharmacy at UBC Vancouver. For the past 30 years, he has been working as a clinician and researcher with patients with cardiovascular diseases, and now he spends most of his time doing patient-oriented research involving patients with atrial fibrillation. So this is our awesome panel who will now begin their talks, and so please write down your questions. We are looking for lots of questions, and we will start off with Dr. Kevin Pistawka.
Thank you. Thank you, Kathy, for inviting me and the panel for joining me today. It's my first Café Scientifique experience. There's been a few of them. It sounds very European. I wasn't sure what to expect, a canapé and a glass of rosé, but I guess the one thing we'll expect is most of us who haven't eaten will be having a dinner in a fashionably late European style after this. Hopefully we won't run too late. So thank you for this. Yeah, I've been asked to talk about atrial fibrillation, and it's something that we see every day, and it certainly is a huge part of my practice. I think my title for this talk is The Many Faces of Atrial Fibrillation, and sort of a subtitle would be, well, it depends. Because atrial fibrillation is something that's really quite varied in its expression and where it falls into people's lives and how it's expressed. So first of all, I'd like to thank you all for coming out. I've certainly been a strong believer in education. As mentioned, Kathy mentioned that I'm part of the COACH Rehab program, which does a lot of patient education. I think knowledge is key. The more that people can learn about their health, the better they are to help manage things and try to make sure that we use resources responsibly, make sure that they're doing their part in sharing care with us as physicians. So thank you for doing that. As I mentioned, atrial fib is unlike many diseases. Some diseases in medicine, you have appendicitis, you take it out. It's kind of one sort of disease, one sort of treatment usually. Atrial fib, however, the treatments and the expressions vary, and if I see 50 different patients, we would probably treat them 50 different ways, and that's why it makes it challenging for patients to kind of understand the disease, their journey, and compare their footnotes with their neighbors. First of all, I've been asked just to give a general overview of atrial fib. So some of you would have a lot of knowledge, some of you would have less so. Certainly it's very, very common. 5% of people over 65 develop atrial fibrillation. It increases with age, so the older you get, that higher number goes. So if you reach 90, probably a third of you are going to have atrial fibrillation. It certainly is highly prevalent disease. So if we actually look at what percentage of the population, 2% of the population 10 years ago had atrial fib. It's probably more common now because we're actually detecting it a little bit more because of the various monitoring devices that people are wearing and using. So we're seeing it's sort of a new disease that's kind of wearable atrial fib, but it's certainly common. So if we do the math, IHA is 700,000 people, kind of everything northeast of Hope. There's 700,000 people in IHA, so there's probably 15 to 20,000 people who have atrial fib in our health authority alone, so it's hugely prevalent. So what does atrial fibrillation cause? Why do we worry about it? Well, in some patients, it actually causes nothing. First of all, to describe atrial fibrillation, I'm going to go back a little bit. I'm sort of like describing things when we talk about cars. So when I talk to patients, I often talk about, this is a problem with your gas lines, and that's where we talk about stents and bypasses, or this is a problem with your valves, or this is a problem that you're only firing on 2 cylinders and not 6 cylinders. Or I talk about, so atrial fibrillation from a car perspective is kind of an abnormality of your distributor. Your timing mechanisms are a little off, and the heart becomes irregular for various periods of time. You can have other things wrong with your heart. So like your car, you can have valve problems that coexist with the timing problems. You can have pump problems, or you can have gas line problems, but they're not necessarily linked so they can be associated with each other, but not necessarily causal. We usually define atrial fib when someone's had it for at least 30 seconds. So the heart goes out of rhythm 30 seconds, but that's a pretty narrow definition. And many patients have obviously a much higher burden. And there's some patients that have it for decades and decades and decades. And I have some patients that I've been in my practice since I started, and they've had atrial fib at the beginning, and they still do now. So it's quite variable in its duration. So what does it cause? As I mentioned, some patients have it, nothing happens. They're just kind of, the heart goes flippity-flop, and they live with it for years, and it doesn't cause any grief. Some patients can cause symptoms, but not much more. Symptoms of breathlessness, fatigue, anxiety. Some patients can have devastating complications from atrial fib. So the biggest one is it can cause strokes. So when the heart becomes irregular, clots can form, and they can travel down to the legs, they can travel to the kidneys, but they most commonly can travel to the brain. And about 1/4 of strokes are related to atrial fibrillation. If the heart goes fast enough for long enough, it can wear itself out. So atrial fib can cause heart failure just through kind of overdrive by being too fast, too long. And we see that fairly commonly. So there's quite a range of problems that atrial fib can cause, from something very, very serious like a stroke or heart failure to, in some cases, patients really cause not a lot. Atrial fib typically doesn't cause heart attacks, however. So that's sort of more of, as a cardiologist, we think of a heart attack as a plumbing problem. Your gas lines blocks arteries. So the two are typically unrelated. What symptoms? As I mentioned, patients can have no symptoms. They can be short of breath. They can be anxious. They can have chest pain. It's quite variable. Some patients with atrial fib are astonished to know that people have no symptoms. And we have patients walk in for a colonoscopy or a knee replacement, and they're in atrial fib, and they don't even know it. And that's very, very common. So the question is, well, what causes atrial fib? Well, this is, again, well, it depends. So some patients can have atrial fib because of an unhealthy lifestyle, because they've had too much alcohol, maybe they've gained a little bit too much weight and have high blood pressure as a result, or sleep apnea as a result. And certainly lifestyle can contribute, and that's where self-care certainly plays a role. Alternatively, we see some people have atrial fib because they're too healthy. We see atrial fib certainly more commonly in triathletes. And obviously, atrial fib increases with age. If you're healthy enough that you don't have a lot of other diseases in your 60s, 70s, and 80s, you live long enough to 90, well, being a healthy 9-year-old unfortunately puts you at risk of being atrial fib. You can also have atrial fib from other heart problems like leaky valves and, like I say, weak heart, irritation of the heart, sometimes from COPD, sometimes thyroid. So there's a lot of different causes, and that's our job to explore those causes. Once you have atrial fib, then the question is, well, what triggers it? Well, it depends. Some patients have no triggers. It's like forest fires that start, we don't know why they started. Other times, it's obvious what started the forest fire. And in some cases, atrial fib, that spark can be alcohol, it can be stress, it could be caffeine, it could be a cold drink, it could be a surgical procedure, it can be, some cases exercise. So there are quite a variable amount of triggers, and it's frustrating sometimes when we don't find the trigger. Well, how do we investigate it? Well, it depends. In some cases, we'll do heart monitors, ultrasounds. In some cases, we'll go looking for artery problems. In some cases, we'll look for sleep apnea. So there's quite a range of investigations we will use to help decide how we're going to manage this. And then how do we treat it? Well, it depends. So if it's happening very infrequently, very short, we might not do an awful lot. For some patients that have a huge impact on their lifestyle, we'll use medications, which obviously the pharmacist will hear more about. Peter will learn. And some medications are very successful. Some medications are not really successful. Some medications cause side effects. So it's really quite variable as each patient as to how we manage. And often it's a journey in trying these various things to see whether, and really a bit of an experiment and trial and error to see if they're going to work for individuals. What other things can we do? Well, again, the treatments can vary from let's do nothing to do something very, very aggressive and invasive. So what would be more aggressive? Putting electricity paddles to someone's chest and putting 360 joules of electricity for them, through them to reboot the heart. Likewise, we can also stick catheters up inside people's hearts and make 80 to 100 burns inside the atrium using cautery in an attempt to cure these. So we have some patients where we do very little to, and some patients where we become very invasive and very aggressive with. Typically, a pacemaker doesn't fix atrial fib. That's typically for slow heart rates, and typically atrial fibrillation is fast. So we usually can't subtract beats with a pacemaker. We sometimes need a pacemaker. So do you need a pacemaker with atrial fib? Well, it depends. If the drugs we're giving are causing your heart to go slow, so sometimes we will. So some patients with atrial fib will end up with a pacemaker, but the majority of them don't. What is our success rates of the meds? Well, it depends. It depends on whether the patient has good compliance, whether they're managing their lifestyle. It depends on what their underlying heart condition is. It's really quite variable. And what is the success of some of our ablation procedures? Well, in some patients, we could predict the success would be close to 0. In other patients, we'd predict the success rate would be as high as 60 or 70%. So you can see that this is a disease that is highly variable in its expression, a lot of different experiences, a lot of different causes, triggers, treatments, management strategies. But today, we're going to explore self-management as one of the main things. So again, I look forward to hearing from all of the individuals, maybe some of you tonight, to share with us your experiences on self-management of atrial fibrillation, because it's something that certainly we want all of you to be involved in your care with us. So thank you for coming tonight.
That's great. Yeah. So we're going to pass it on to Cheryl now.
I'm really curious, and I'm wondering if people are comfortable showing how many are here that have AFib. Okay, thank you. That's part of my social work coming out in my life. So for me, just a little bit of background context. I'm 64 years old. I'm a retired, as was mentioned, social worker. I live alone. I have 3 adult children, 2 great-granddaughters. And my journey began roughly in 2017, so I'm fairly new to this. Some people have lived with it a lot longer than I have. And part of it was I was aware that I was experiencing symptoms for about 1.5 years before I officially was diagnosed. I had no clue, though, that it was AFib that I was experiencing. And often it was, as I was falling asleep in bed, I would notice this thumping in my chest. So I was, throughout this journey, I've been fairly aware of episodes that have been going on for me. And as well, I was attending a gym that used digital devices to track your heartbeats, and mine was always off the charts. Like it wasn't recording properly, and so we were continually changing these monitors to try to get correct readings, and I again did not know that this was related to AFib. One of the local gyms here, I won a gym membership for this particular gym, so I went. I thought, okay, I'll give it a go. So that, and then I'm just going back. I've got cheat sheets here. Cheat sheets. So I had my general practitioner of 30 years retired in about 2018, and I was referred to another family physician, and I just happened to be with the first meeting with her. I just happened to be in an episode. So she sent me directly to the hospital without doing anything else, and I had an ECG there that confirmed atrial fibrillation. So from there, I bet you it was about 6 months of various procedures, starting with I don't even know the terminology anymore.
Echo.
An echo, thank you.
Echocardiogram.
Thank you, yeah, I had that. I had Holter monitors. I was referred to the sleep clinic to check for sleep apnea. What else would I have been referred to? I can't remember, it was about 4 years ago, but there was a lot of different procedures just to confirm what was going on for me. And so after all those, I think it was after all those, most of those procedures, the cardiologist at the time diagnosed me with a type of AFib called
paroxysmal.
Thank you. Some of you may know that term. There's 3 different levels of this type of, or just AFib, and I just happened to fall into this one. And that type of AFib is, expresses in temporary episodes that come and go. So they start suddenly, and then the heart returns to a normal beat on its own without medical assistance, usually within 24 hours. So when I look back on the time I was in, likely had AFib, some of those, without medication, some of those episodes would last 24 hours, and I can never figure out why I was so damn tired, and just exhausted. So I was started on a blood thinner, a rhythm, and a rhythm, and what's the other one?
Beta blocker.
Beta blocker. Thank you. See, I know these things, but I'm under pressure here. Sorry.
Doing well. Doing great. Hope you don't get atrial fibrillation.
Right. No. I had those over the weekend. So once I was diagnosed, though, I was really on a mission to educate myself about this heart disease. And a lot of my potential contributing factors that I uncovered during this time, both my paternal grandfathers died of heart attacks. Now, this is in the 60s, so what was going on for them at the time, was there AFib involved? I don't know, but there's a cardiovascular that runs through my family. My mom had a ruptured aneurysm about 15 years ago, and she now, well, not because of that, but she now lives with AFib as well, and she's in her 80s. So this is a very genetic contributing factor for me, I think. Age, I'm postmenopause, about 9 years, which is, I found, discovered that is, for females, can be a contributing factor. Through the sleep clinic procedure, I was diagnosed with a mild sleep apnea. So I tried a month of the CPAP machine, but I couldn't tolerate it. So at this point in time, that was a number of years ago, we just left it, and now I'm looking into dental device to see. So again, I've been referred back to the sleep clinic to assess whether this will work or not for me as well. But we just decided not to go with the CPAP machine because I couldn't sleep with the darn thing. So I was losing sleep and then requiring sleep medication to help me sleep. And I thought, well, this isn't, for me, it just didn't work, right? So, and there are many people out there that it is helpful for, I understand, but for me, I couldn't tolerate it. Some of my lifestyle contributions when I kind of started looking at the disease, and for me, I grew up in a home and was surrounded by people that smoked cigarettes, so I was around cigarette secondhand smoke from time of birth. I, too, started smoking because of the role modeling that went on for me. I never was a heavy smoker. I was more a social stress smoker. So, you know, that I just kind of look at it as being part of the context for me. And then at about 33 years of age, because I had the 3 kids then, I had decided no more smoking in the house or in the vehicles. So that was the first step for me when I was 33 years old, to try to eliminate that from that lifestyle for me and my kids. And currently I've abstained for 4.5 years, and I've had over 10 years of no smoking in past as well. So I drink socially. When I had the 3 kids, there was 10 years of non-use. I had a lot of stress contributions, so I was divorced at 32, single parent of 3 kids, went back to university and obtained 2 degrees. So lots and lots of different stresses, yeah. My personality type, I always like to include that because I tend to have leans towards perfection, control of things I have no control over, anxiety. I'm a highly active person. I'm an extrovert. I don't like to sit still too long. I'm also a caregiver, and some people refer to that as a type A personality. Yeah, so that's, and then, but you know, over the years I have gained improved coping skills, and not just in the last 4 years. It's been for, you know, many, probably 2 decades. And, you know, I'm always kind of looking at those ghosts. And I still got AFib, even though I tried to, you know, improve my coping skills. So some of the medical advantages to me for living my best AFib life includes cardiology, pharmacy, other specialists, medication to reduce the risk of particularly stroke. I do have periodic breakthrough episodes that even though I take my medication on a fairly structured basis, and I just take care of myself during that time. I use a device called Cardiomobile. If you're not familiar with it, you might want to check it out. It's an app and a device that you can get at Best Buy for $100. And I send the readings. It's like doing a mini ECG for 30 seconds, and I can send the readings to my cardiologist. And I sent her, I had a meeting with her yesterday, and we reviewed, I just got it in at Christmas, so we just reviewed them together yesterday and how to best use them and those kinds of things. And I'm currently on a wait list for a catheter ablation. And just overall, lifestyle, what I've come to believe is that I can, you know, what I do 80% of the time is good enough, and how I cope matters. I remain active and do activities I enjoy and make me happy. And I appreciate the 4 quadrants of my life. So, you know, all the physical piece, you know, so looking at, you know, good nutrition, all those things. But 80%, I'm not perfect. I'm not, you know, there's days or weeks that I go, to hell with it, you know. Socially, people are really important to me. And psychoeducation is really important. And that is me.
Thank you, Cheryl.
Thank you very much, Cheryl.
Yes, over to you, Ryan.
Great. Oh, this mic is really loud. So my part is going to be bringing it to looking at the evidence that we've gathered in relationship to self-care. I've been working on a self-care research project over the last 2 years. I got a Michael Smith grant that's funded this project. So what I'm going to be talking about is probably what you're really interested in. What is self-care? And how can it help my life? So the first thing I'm going to talk about is how are we defining it? So when we're looking at self-care, we're looking at 3 different things. So the first part is self-care maintenance, and some of the things that Kevin talked about is managing your risk factors, getting enough exercise, keeping your stress down, making sure that your BMI is low. If you have diabetes, making sure your diabetes is under control, smoking cessation. So those sorts of things that improve your overall physical health and even psychological health. The next part of self-care, which is important, is monitoring. And this is really important with AFib because unlike other conditions, you have to be able to know how to monitor your heart rate if you're really going to engage in your self-care practices. So you have to know how to take your pulse, know when it's rapid, know when it's slow, know when it's irregular. It's a good idea to know what your blood pressure is and have ways to take your blood pressure at home. So that's part of the monitoring aspects that fit in with self-care. The last part is management, self-care management. And so when I say that, I'm not saying we want you to be able to manage your own AFib care, but it's to learn to be involved, to know what to do when you have symptoms, to know a lot of patients when they get symptoms in situations where it's paroxysmal AFib, where it comes and goes, would not wait it out and would go and go to the emergency. So a lot of treatment seeking for things that if you had a plan in place and you knew that you were safe and you were stable, that you could just wait until your heart sort of went back into a regular rhythm, and then you could carry on with life. So having the knowledge to be able to have an AFib plan is very, very important. And it improves, I'm going to talk about some of the research about if you're involved in your care, if you have knowledge about your AFib, if you know how to monitor it, how much better your overall quality of life will be, potentially. The research is showing that you'll have less symptoms if you're involved in your care and you're doing things to sort of maintain your health. So that's what I'm going to look at it from a research sort of perspective. So I know there's a lot of patients here, so I hope I'm going to try to keep it at a level that I'm not getting way into all the statistics and stuff, but just try to keep it at something that you can help apply to your life. So I'm going to give you a number here, 8,760. Does anyone know what that number is?
Yes.
It's the number of hours in a year, okay? And guess how many hours on average a patient spends with a healthcare provider? 0. On average, it's 10. So 10 hours, that's 0.001% of your time. So when we say self-care, what I'm sort of trying to get at is that we can't put everything on healthcare providers to think we just go to a provider, they tell us what to do, and then it's going to fix everything. There's a lot of all of those other hours in the day that it's up to you to make sort of decisions that's going to help support your health. So self-care has been recognized by the Canadian Cardiovascular Society as something that's really important and that we need to really engage patients in. But we know that patients in BC struggle with self-care, that they don't have adequate knowledge, they don't have adequate support from their primary care providers, and so that's part of why we're doing this research, as to how can we develop ways to support patients, particularly through primary care. So what do we know about self-care? We know that it works. Oops, turning the mic off. We know that it works. Research shows that if patients are engaged in their care, it decreases your overall chance of mortality, morbidity, stroke, lessens your chance of developing dementia, and cognitive decline. If you practice poor self-care, you have higher access to healthcare services, lower productivity, as I said, your quality of life potentially is not as good, and it can lead to depression and psychological distress. So if you don't have knowledge of that, your heart rate, that it is okay when you go into these events, if you know that it will correct itself, or if it doesn't, that you have a secure plan in place, that's really distressing for patients when they don't have that knowledge and that understanding. So what are some challenges with self-care? One of the, what's going on with this mic? What's that? Oh, I'm turning it off, okay. One of the main challenges is it's hard to do anything for a prolonged period of time. So if you have a gym plan, it's how long, into the new year, how long does that last? And another part that Dr. Pistawka talked about is a lot of patients don't have symptoms. So 30% of patients don't have symptoms at all. So now we're telling them to take medications and do all these things to reduce their risks, and they feel fine. So it's really hard to kind of get patients to buy in on those things. The other part is a lack of knowledge. So if you walk around, and I tell people what I do for my work and what my research is, and they kind of glaze over. I study AFib, and so many people don't know what AFib is. You know what a stroke is, you know what a heart attack is, but AFib, there's just an overall lack of knowledge that's surrounding what it is. And again, I talked about the primary care. So the majority of patients get care through the primary care level for their AFib. We have excellent specialist services, for sure, AFib clinics, but a lot of patients don't make it to those services, and they're treated at a primary care level. And we all know what primary care is like at the moment. Everybody is overstretched, overworked, and there isn't enough resources set up to really help manage self-care and to spend time educating patients in that scenario. So that's part of what our work is looking at. So how can we help support patients in that primary care setting? So how did we do this with our research project? We did three things. So the first thing is we did an environmental scan. Before we started our research project, we wanted to see what's available right now. Maybe primary care is working fine. Maybe specialist services is working fine. Maybe patients get enough information on the internet. So we did an environmental scan to look what's being done. And then we did a systematic review where we looked, what does the evidence say? What is the best way to support patients in their self-care? And then we did a deliberative dialogue where we brought providers together, patients together, and decision makers from across the province to what is a way that we can help implement self-care practices in our province. And so I know I only have a few more minutes, it goes quick. I just want to talk about what our systematic review sort of told us about. So the first thing, as I said, self-care works. So when patients are engaged in their self-care, that there's improvement in the symptoms they experience, the stress that they feel. There's also improvement in clinical outcomes. So clinical outcomes are things such as objectively measured AF knowledge. So when you take time with a patient to explain what AFib is, what the risks are, and help them develop a plan, then that's going to hopefully improve their knowledge. So the research showed that having a proper self-care program will improve patients' knowledge. It decreases, has a chance to decrease those biological measures, so helping patients to lose weight, to stop smoking, to not drink so much, and it can effectively reduce their chance of having a stroke. And as Peter is going to talk about, a big part of it is medication adherence. So patients start off by taking their meds, but then over time, what's the point of taking these? I feel fine, or all the other reasons why we might stop taking medications. So a lot of the research that we looked into is supporting patients in unique ways on how to take medications on a daily basis, such as reminders on their phone using technology, or when you open your pill cup every day, it documents that you've taken it and gives you a congratulations on your phone. So there's different methods and ways that they're using technology to help support patients in that. So I actually, when I went into this, I thought everything is going to be tech-based, that all of the interventions moving forward are going to be tech-based. But what we found is that patients don't just want tech-based, they want time with providers, they want time where people can explain things. So when we brought together our deliberative dialogue, we asked what are the priorities that we should think about when we're trying to help design an intervention to support patients. And the first thing or the three things, and I'll end with this, is it's important that we have a personalized patient plan, that it isn't a one-size-fits-all. Like Kevin was saying, there's so many different flavors of AFib, and we can't just say you need to do this to sort of improve your self-care. That we need to take time and understand each patient, what their challenges are, and develop a plan that works for them. The other thing is it needs to be a team-based approach. So in primary care, it can't just be the physician. There just isn't enough time. It needs to be an approach where we use nurses, where we use pharmacists, dietitians, physiotherapists, and we all come together to sort of help support you and develop an intervention that sort of really supports you in your ability to understand where your AFib is and have a plan to move forward. And the last piece that we kind of came up with is it needs to be reliable, because there's so much information on the internet. You have to know where to get reliable information. And this, whatever we design, and that's our next step, is to actually implement it. Whatever we design, it has to have a mechanism that it has reliable information that is up to date, because we all know you can go to your doctor's office and you can get papers and pamphlets that are really outdated potentially, and all kinds of different information. So this kind of stuff is, with research, things are changing all the time. So it has to be a way that it's reliable information. So that's what we're tasked with. I know hopefully there's some questions come up. I didn't get into what are all of the actual self-care things you can be doing and what, but it focuses on sort of those maintenance pieces, trying to minimize your risk factors, monitoring, make sure you know how to take your pulse, and then those management pieces where the most important thing is to have an AFib plan, to know what to do when symptoms come on, and know when you should go to the emergency or when you can wait it out. So sort of having that knowledge to move forward. Thank you.
And last but not least, Dr. Peter Lewin.
Thanks, Kathy, and thanks everyone who's got you and your thoughts and questions percolating so far. And maybe, I'll ask you to help me guide what I share over the next couple of minutes with just a couple of preliminary questions. So many of you here are living with atrial fibrillation, almost all of you based on that show of hands. Who here takes any kind of medication whatsoever for their AFib? Okay. Most, and so you have lots and lots of expertise through your experiences with that and the education that you've received, and probably that you give to your friends and family about what you've learned about this. And so through the questions that you bring forward, hopefully we can get into lots of the nuances. I'm going to take a risk and use the time that I have to mostly focus on some newer developments that are happening in how we use medications to treat the various aspects of atrial fib. And it's taking a chance in the sense that I'm imagining that might be one thing that you want to hear about this evening. And if you want more detail, ask questions and we can go into more detail. If you want less detail, say, what in the world were you talking about when you were saying that other thing you were saying? And we can try to explain it in a different way. But there's kind of three main aspects of how we use medications in patients with atrial fib. And to me, this is all in the domain of self-care. So some people, not me, think that, well, getting a prescription and just being told to do a thing is not self-care. That's just being told to do a thing. Of course, you know that every day when you make a decision about whether to take a drug that you've been prescribed, or do an exercise intervention, or monitor your pulse, or take an ECG, that is all self-care. Those are all choices that you make every day. And so it's my belief that that you ought not to do any of those things if you don't have a pretty good idea as to why you are doing them and what's relevant about that. And so that's kind of the perspective that I'm coming from. So I know there's folks who are like, I have no idea why I'm doing this. I was told to do it, so I'm just doing it. I get that, but I also am a believer in that you being as empowered as you can be in all aspects of your healthcare being a super important way for you to get what you need. and what you want. So anyway, that's a lot of preamble about where I'm coming from. But we use medications in three main ways. We use them to, as you know, help keep your heart rate under control. And by that mean, usually we're talking about trying to keep your heart rate from going much above 100 and from keeping, and that's what we're using the medications for. Sometimes the medications we use cause your heart rate to become lower than is desirable. So, less than 60 and sometimes even less than 50, which is usually undesirable. But everybody's target or goal or range is a little bit different. Those are the generalities, and those of you that take medication to control your heart rate know about this already. And there's actually not that much happening in the science and the evidence and the research around AFib that has to do with controlling the heart rate specifically. Most people are able to achieve their goals heart rate wise with the beta blocker medications and the verapamils and the diltiazems. And I'm using specific drug names because some of you people are taking those medications and are very conversant in them. So that's all I want to say about that. But if you have more questions about that aspect of it, we got time to talk about that in our time together. The other aspect of AFib that we use medications for is in actually controlling the rhythm. So trying to keep you from being in AFib, having you instead being in normal sinus rhythm. And this whole area of what we call rhythm control is one of the biggest areas where things are changing in the world of AFib. A concept that is influencing a lot of where this is all going is we now have a pretty good understanding that being in atrial fib begets more atrial fib. In other words, being in AFib it results in progression of AFib. And so the idea behind helping patients who are good candidates for being converted back into sinus rhythm and being kept in sinus rhythm, whether it be through medications or through the ablation procedures that Kevin has mentioned already, either of those are ways of getting people and keeping them in sinus rhythm. The science is showing us now that can produce some long-term benefits. And in particular, there's been a couple of really big influential studies that have shown that doing that, and doing that as early as possible in the course of a patient's AFib journey can result in improved quality of life, reduced symptoms. Those are probably not surprising, but also reduction in overall cardiovascular risk, and even and reduced risk of stroke, and a very small reduced risk of death overall. So this is where things are going in terms of how we understand rhythm control in AFib. The other thing we understand, and many of you, some of you have probably had an ablation, some of you are on a list for ablation, some of you are curious about ablation. And I know that some of you are probably taking medications to keep you in sinus rhythm. We call those anti-arrhythmic drugs. We know now from some really big studies that ablation is more effective than anti-arrhythmic drug therapy. It's more effective for keeping patients in sinus rhythm. It's therefore more effective at helping patients be symptom-free or having reduced symptoms. And it's not entirely clear yet whether it prevents some of the other, that it's better in terms of stroke prevention and overall cardiovascular risk than drugs. But this is one of the reasons why ablation is a favored means of achieving rhythm control. Drug therapy is better than nothing in terms of achieving rhythm control, and in properly selected people that are good candidates for it, drug therapy is a completely appropriate and useful way to achieve some of the goals that we're talking about. So those are some thoughts about rhythm control. And then the domain that I'll comment on is about stroke prevention. So again, only those of you who are willing to disclose. Does anyone take a blood thinning medication to prevent strokes? Okay, so lots of experts here in the room. And this is an area where most of the research that I do is. So you've been told, but I'll remind you that the anticoagulant medications, those blood thinning medications, we'll name them, you know them, warfarin, dabigatran, apixaban, rivaroxaban, edoxaban. Those are I'll use generic names. I'm trained as a pharmacist to use the generic names. Those are extremely effective. In the world of drug therapies, I mean for anything, for any condition, not just cardiovascular, those medications are the most effective preventive medications we have. They prevent approximately 2/3 of strokes that would otherwise happen. So the statin you're taking, the aspirin you might be taking, or I hope not taking if you're also taking an oral anticoagulant, we can talk about that. You think of other the blood pressure medication you're taking, all useful, but none of them are as effective at doing what they're supposed to do, which is preventing strokes, which is what you're taking the oral anticoagulant for, extremely effective. The other thing that we've learned, and this would apply to none of you, is that only about half of patients in British Columbia, and we've just finished studying this over the last 15 years, all patients in British Columbia were involved in the study that we've done, including some of you. Don't worry, we don't know any of you by name, but we have all your PharmaNet records, we have all your hospitalization records, completely in a way that there's no way for us to identify anyone. And we know, and again, this applies to none of you, that only half of people with AFib that are prescribed oral anticoagulants take them reliably. Patients with AFib who are prescribed oral anticoagulants miss, on average, 31% of their doses. Yeah, that's none of you I know. That's surprising. And in fact, we've done lots of studies where we interview patients directly and ask them how adherent, that's the word we use, like how reliably they take their oral anticoagulants. And about 95% of them say they have never missed a dose in their life and they take them all completely reliably. But we have the records and we know that that's just not the case. None of you. But that's what's going on in that world. Okay, so who cares? Well, the other bit of emerging science, and this is research that we're doing, is that it really, really does matter in terms of stroke. And so what we're just finding this month, just pulling the final results together, is for every 10% drop in oral anticoagulant taking, so call that 10%, call that like missing 1 day out of 10. That would be an example of that, or missing 1 extra day out of every 10. For every 10% drop in taking it reliably, you got about a 20% to 25% increase in your risk of having a stroke. And that risk is even more pronounced in people who take the new oral anticoagulants. So you've got your warfarin, your Coumadin, that's one of the old ones, and then all the other ones that I named earlier are the new ones, the direct or novel oral anticoagulants. The risk is even higher for missing doses of that. And the reason is they're really short-acting compared to the rat poison, the warfarin. That's what patients call it. Missing doses of warfarin is very undesirable in terms of stroke risk, and missing doses of those newer ones is even more undesirable in terms of increased stroke risk. And so this is a really big concern that applies to none of you, but I share that with you in hopes that you can maybe convey those ideas that are new and emerging in the AFib world to the people that you care about who are similarly affected. And maybe there's lots more to talk about, but maybe we'll leave it to your questions to be the way that we get into much more detail, and there's lots of other topics about AFib that I'm sure all of us would love to talk about. So I'll turn it back to you, Kathy.
Excellent. Well, that was a great panel, and we are looking forward to questions. But before we break, and just on the tail end of Peter's presentation, we have this man here who's going to do a stroke stretch break.
Yeah, here we go. So Peter, thank you for talking about the stroke. It's very, very important. Again, this is probably one of the most devastating complications of atrial fibrillation, and it varies. So we see some patients who are at very low risk of stroke where we decide not to anticoagulate. Typically, those are much younger patients without some of the risk factors like high blood pressure, diabetes, age over 65, having a weak heart, or having had a previous TIA. But I'm going to show you some sense of the numbers. So first of all, just to give you an idea of what the numbers are all about, let's everybody stand up here. So I'm going to say we have 100 people, and we're going to say what happens over a 1-year period. So we treat patients with blood thinners. Most of you are going to be pretty okay. So I'm going to say everybody sit down except these two, this table and that table. Everybody sit down. Now, whether you were on blood thinners, most of you would have been fine for 1 year. But this is what happened in that 1 year. I gave you blood thinners, and this table, oh, darn Pistawka, you gave me blood thinner, and I got hemorrhoids, and I bled out and had to dealt with. Or I got a nosebleed, and I had to have someone put a rocket up my nose. Or I had, cut myself, and I was in emergency getting stitches, and it was a real nuisance. Or I'm bruised all over. That's what I'm causing. That's what I'm going to do. I'm going to cause out of 100 people, maybe 1 or 2 to have bleed. I'm going to, however, prevent this table from having a stroke. And most of the atrial fib strokes are devastating. They can cause loss of speech, loss of arm strength, loss of ability to care for themselves, loss of driving. You end up in cottonwoods, and in some cases care either at home or in a facility. So I can ask yourself, at 1 year, which table do you want to be at? This table, where we're going to cause the 1 or 2% chance of stroke, or 1 or 2% chance of bleed, or this table, if I don't give blood thinners, this is going to be the table with stroke. So those are about the numbers. 1 or 2% risk with a 5 or 7% benefit. And each year you can imagine if I took this 2 years, now we've got another 5 tables, another 5 people at that table. 3 years, 4 years, 5 years. So if you have atrial fib for 10 years and you're over 65, your lifetime risk of stroke is half of this room. So there's an illustration of the importance of stroke prevention. So that's a little bit of a break.
So with that, we are going to take a quick break then. We said about 10 minutes. 10 minutes, we'll call you back. So there's some water and little snack at the back. And restrooms over here. So just get up and stretch, and we'll reconvene in just a few minutes. So I think we probably should reconvene and start our question period. I know everybody's got burning questions. It's been great meeting many of you. We've appreciated the interactions, and we are looking forward to hearing from you and sharing maybe some of your experiences and getting some of your questions addressed by our expert panel. We're just waiting for one more person, so just get yourself all prepared, and we are going to have Lindsay with a microphone. So maybe it would be easiest just to raise your hand so that she can take the microphone to you, and she'll be running around kind of passing it from one person to the next. So.
Hi, I've been on, I guess it's 9 years I've had AFib, and I've been on bisoprolol for that amount of time. I guess I'm wondering, is it time to really go in and talk with my cardiologist a little bit more and try to change it, or what are the long-term effects of bisoprolol? That's all.
So, and we're gonna be real delicate about giving anyone individual health advice here. So, I guess we can start with that. Is that a fair ground rule for us here? Yeah. So, I'll just speak in general. So, just generally speaking, and anyone else here can chime in as soon as I'm done. But in a situation like yours, we would be continuously interested in making sure if you continue to have atrial fib and it's relatively persistent or permanent, that you are kind of on an annual basis, that we have a pretty good idea whether you're a candidate for anticoagulation to prevent strokes, because as Kevin said earlier, we look at risk factors there and to decide whether to initiate that or not. So you look like a young person, and so it's we would be interested in that. So just speaking to the beta blocker part alone, the medication he named, bisoprolol, that's a beta blocker. That's just there to control heart rate, basically. And so whether, from a long-term risk point of view, it's neutral. All it's doing is, in an AFib situation, is keeping your heart rate within the goal. It may be doing other things for other people that are taking beta blockers, like helping with their hypertension, for example. For people who have coronary artery disease, helping to prevent them from having angina symptoms. So beta blockers do lots of things, but just in the specific way that you mentioned it, it's just there for heart rate, and it's neutral in terms of taking it for the rest of your life or not.
Yeah, certainly I had no qualms keeping someone on beta blocker for decades. Any drug has potential for side effects, and always matter of weighing the benefits compared to the risks. So if the benefit of that drug has been significant, then you're prepared to put up with some of the side effects. And the side effects can be very minor. They can be quite severe. Some people get sleep disturbance, some people nightmares, some people fatigue, some young guys erectile dysfunction, some people cold extremities, some people just too low blood pressure and low heart rate and dizziness. So when we start someone on medication, we always want to assess, is this medication doing more benefit than harm? And if it's not, then it should be reevaluated. If there's side effects that are concerned, often there are lots of alternatives, whether they be other medications or other procedures. So I think if there's certainly concern about medications, and if any medication you've been on for a decade and you haven't had it reviewed, it's probably time for a review.
Agree. And actually, for mysterious reasons, quite a few patients with atrial fibrillation their heart rate does not get elevated, so they don't experience that rapid heart rate. This is a minority, but there are some that just don't, for different kinds of reasons, but often we don't know why that is. So some patients with AFib don't need to take a beta blocker type medication to control their heart rate. Again, we're just using those to control heart rates.
I just mentioned pill in the pocket when it comes up with beta blocker.
Sure, yeah. So what lots of patients are able to learn, and this is a great self-management topic. Yeah, exactly. Say again?
Yeah, it's just one of the management strategies.
Yeah, exactly. So you want to talk about it? So lots of people, they feel very symptomatic when their heart rate is way up. So when it's, it's usually when it's over 100 significantly, it can be over 90, they feel really symptomatic. So they don't have to be taking a beta blocker all the time. And I'm saying beta blocker, but I also could mean verapamil or diltiazem. Those are the other ones that we use. They know that when they experience that, to take a dose of the medication. And so that's just on an as-needed basis, brings the heart rate down. Sometimes the instructions are, if that happens, give a call to whether it's your cardiologist or the AFib clinic or to your GP, that kind of thing. Sometimes it's a pharmacist that's counseled the patient to do that. Other times the episode of AFib passes. As many of you know, it's unpredictable how long any specific episode will last. They revert to normal sinus rhythm. They don't need to take another dose of the medication. We call that pill in pocket.
Yeah, just one caution again. We're not saying if you're taking beta blockers all the time, let's suddenly stop it and just take them only as needed. That should be something that should be discussed. There is such a thing as beta blocker withdrawal. So if you suddenly are on it for years and you come off it, you can't actually get a bit of grief. So patients on a good dose of beta blockers, we often will wean off of, so they don't go through a kind of a withdrawal phenomenon of faster heart rate and higher blood pressure. So.
So I was just wondering if, does AFib contribute to higher blood pressure?
I'll take that typically the other way around. So typically high blood pressure is probably the most common cause of atrial fibrillation. So when your blood pressure is high, your heart kind of gets stiff. It kind of squeezes okay, but it doesn't relax very well, like bellows that aren't really unwinding. And when the atrium, the priming pump, is trying to pump blood into that ventricle, it's stiff, the atrium enlarges. So years of high blood pressure are often a very, very common cause of atrial fib. Certainly if you get stress and anxiety during a spell, that can elevate what already might be, sort of high normal blood pressure. But typically atrial fib in itself, it generally, apart from the anxiety effect, it shouldn't be putting up your blood pressure. the other way around typically.
Okay, thanks.
And that's why it's important, again, for patients to monitor their blood pressure, to know whether their blood pressure is being adequately treated, because one of the most common causes for atrial fib is blood pressure that's not quite where we want it to be.
Hi there. My question is, when should you go to the hospital? After how many hours or days? You're not terribly symptomatic, you're not falling down, but when should you go and bother the poor hospital?
Great. Yeah, I'll take that. Yeah. So when you have an AFib plan, there's 3 zones that they kind of say that you should kind of fall, or that you should monitor your heart rate and your health with. So the first one is a green zone. So if you are in the green zone, everything's good. Your heart rate is less than 100. You don't really have a lot of symptoms. No kind of actions required. Of course, you're in a safe spot. And again, this is for people that have, I did a lot of work with trying to, if you've never been diagnosed with AFib and you're starting to get palpitations and that's a different scenario where you want to get a healthcare provider opinion to make sure that, maybe you've been having AFib events for a long time and you're not getting any anticoagulants and you're, as we know, a great risk for having a stroke. But once you have a diagnosis of having AFib, you can talk to your provider about getting a plan about when should I go to the hospital, so that you're not going, like you say, every time you have some symptoms, you're going to the emergency room and then waiting and then them sending you home or whatnot. So the next zone is sort of, they call it as a yellow zone. And this is all, I wanted to say, this is all in the Cardiac Services BC and Interior Health website has this pamphlet that you can download. And it has all of this information, all the self-care information in it. So I don't know if we can have ways to link to this information afterwards or any way we can disseminate it, but it's Cardiac Services BC. You can search AFib there, and I don't know the link for the Interior Health one, Kevin, I don't know, or Coach, but this is a really good self-care sort of full package that has all of these zones and everything, and when should you talk to your provider, has all of that information. So the yellow zone is usually, if you're in a yellow zone, you're having more symptoms than normal, more palpitations, shortness of breath. And they say you should call a healthcare provider if you're in that yellow zone for a period of 12 to 24 hours. So if you are feeling more short of breath than normal, you're having more palpitations, then that's when you should sort of wait to see if it passes in 12 to 24 hours. If it hasn't, then you should contact your healthcare provider. And then the red zone, of course, is if you are having symptoms like chest pain, extreme shortness of breath, syncope, so you fell down because you're so short of breath, then you need to seek emergent treatment for those sorts of symptoms. Is there anything else to add? Or?
Yeah. I mean, I think the reality is what we're going to do in hospital emergency. Number one, in most cases, if patients who have atrial fib, they've got the diagnosis, they're on an anticoagulant or blood thinner, you're not going to emergency to prevent a stroke. So if you're on the blood thinner, you're not going to have a stroke if you're in atrial fib because you're on the blood thinner to prevent that. Right. If your rate is controlled, and you're, again, as mentioned, your heart rate's not particularly fast, your heart's not going to suddenly wear out. Typically, we see patients with heart failure, they've been in atrial fib at fast rates, like over 120 beats per minute for weeks or months. So you can actually be in atrial fib for a long time before it kind of really poops your heart out. Now, some people might poop out quicker. If they've got, weaker hearts or leaky valves and, other things going on, or coronary disease, they might get into trouble quicker. So I think it is a little bit of an individualized decision. But the one thing that emergency does, and they love doing it, it's, they putting people to sleep and giving paddles and shocking the heart back into rhythm because it's exciting that all the junior guys get to watch and do it and be involved and whatnot. And so it's kind of, so it's sort of something that the merge guys love to do. And sometimes there's almost a bit of a false sort of messaging giving on that, geez, you should have come in sooner so we could do this even earlier. I think as long as you're on blood thinners, you're comfortable, that many patients can safely sit at home because many of these spells will last. So I tell some patients, if they've had a cardioversion before, kind of when you think you're ready to get a cardioversion and you're fed up with it and you're kind of not doing stuff, you want to play pickleball, but you don't feel like playing it today because you've been in atrial fib for 36 hours, and you're ready for a cardioversion, and then you go into emergency, make sure you have an empty stomach and get in there, get out of there quick, and then we'll have to come up with a different game plan. I usually tell patients, you know, it's time to think about ablation when they're knowing the emergency doctors on a first name basis. So once you've had a whole bunch of cardioversions, then it's time to think about more invasive procedures. Just a little footnote, we talked about how rhythm control with medications is often effective, rate control or just slowing down atrial fib is effective. I just talked about the 20,000 patients in IHA that have atrial fibrillation. We probably do 4 or 5 AFib ablations a week, so we're probably doing a couple hundred a year. So you can imagine ablation strategies are not going to be the solution for the majority of patients, because the majority of patients can be managed with other means that are less invasive. For those that can't be managed and are having intolerable side effects or are having, like I say, frequent visits to the point where they're requiring frequent cardioversions, it's time to think about those more invasive advanced procedures. And we're lucky we have that here. It used to be people had to go to Vancouver, Victoria. When I came here, there were 4 cardiologists, and I'm a general contractor of cardiology. Since I've come here, we have 4 guys that are pure plumbers that specialize just in the plumbing and the arteries and the stenting. And then we have 2 guys that have joined our group, Dr. Lane and Dr. Baraki, that are kind of pure electricians. And they're the ones that do those procedures. And we're glad to have their expertise. But the reality is the minority of patients in atrial fib in our province and in our health authority are going to need their expertise with catheters inside them.
Quick question, what is ablation?
Okay, sorry. Yeah, okay, oh yeah, we've talked about it in Spain. So atrial fib is a funny thing. It kind of originates up in the left atrium. So the heart has 4 chambers. The ventricles are the pumping chamber. There's one on the left side, there's one on the right side. The right side pumps to the lungs, left side pumps to the body. And then there's 2 priming pumps. They sit above the ventricles and they get the blood into the pumping chambers. The left atrium is the one where atrial fib causes its mischief. And it seems to atrial fib seems to originate in the veins where the blood comes from the lungs into the atrium. So the pulmonary veins are kind of 4 structures that come into the back of the atrium, feed blood into the heart to allow it to be pumped out. It's oxygenated blood. Atrial fib hangs out there, and for some reason, we started to learn more about the electrophysiology of the atrium, and someone came up with a big idea. Initially, it was surgically. In fact, what they said is, let's cut the atrium up into a whole bunch of little bits and sew it back together. And somehow cutting it up and sewing it back together, you create these scars, prevented the atrial fib from occurring. And someone said, hey, that's a big deal. I don't want to have my chest cut open and have my atrium cut up into 20 little bits and sewn it together. Can we somehow create scar in the heart without doing open heart surgery? So this is what's developed. In the last 15, 20 years, we now have procedures where you send a catheter up the vein into the heart, over into the left atrium, and you create 80 to 100 either burns with heat, cautery, or with freezing, like you would freeze a wart. And that procedure is done in a very highly technical lab with 6 or 7 people in the lab, including anesthesia. And it's a procedure that has a moderate success rate in the right individuals. So in appropriate candidates, it has a success rate of about 60 to 70%. So you'll see some people said, I had 1 ablation, it didn't work, I had to go back for a second. And the few that said, I went and I had to go back for a third. So that is a procedure that is, in some cases, is very effective in managing patients' symptoms when these other simpler measures don't work.
Yeah. Has anyone here had an ablation? Yeah, okay. Yeah, one of the things that people who have had an ablation know is that it does not mean you get to not take oral anticoagulants anymore. So we're in a bit of an in-between state here where we don't know whether or not it's safe to withdraw the blood thinning medications after an ablation. So even if you're successfully put into sinus rhythm and you stay there, we still keep the oral anticoagulant on board. So it's not a get out of jail free for having to take medication for that. There's a big study going on in Canada now. In 2025, we'll have the results of it, and we'll know whether it's safe to withdraw the oral anticoagulant. So we may be heading towards a future world where we can, after an ablation that's working, that's successful, that those patients can be relieved of also having to take oral anticoagulant. But we're not there yet.
And at this stage, most of the evidence, and certainly the Canadian experience, has been ablation is largely done not to prevent strokes. It's not done to prevent heart attacks. It's not done to make you live longer. It's done to improve your quality of life. So if we can achieve a pretty good quality of life with other measures, then we don't go for invasive procedures. It's kind of like, you know, if you can, if your knee's not bugging you that much, but you don't go rushing for a knee replacement. You might have some arthritis there, but it's, you know, and when it starts to affect your quality of life and nothing else is working, yeah, then we have these procedures that are available for individuals. It's a limited resource, and right now the wait list is probably at least a year, for 6 months to a year. And there's, like I said, there's,
I just wanted to know how you become a candidate. Last resort?
no, it's something you discuss with your treating physician. It's not, it's something, you know, and again, and I would say, certainly the docs who do the procedure see a lot of the patients that we refer to them, and some of them decide they don't want it, and sometimes they are turned down for various reasons. So it's something that is very individualized, and it's not something that everybody with atrial fib needs to rush off for an ablation.
We've got one at the back, but Lindsay, after that question, this lady has had her hand up. Okay.
Hi, I want to thank the panel for a very informative and I think successful event. One of the things, and I just direct this question to any up there, is as part of your investigations, is there any, you know, when you do blood work, do you look at things that might be putting people at increased risk? For instance, there was a paper from Circulation actually 10 years ago that talked about association of plasma omega-3 levels, and that the people that over 65 that developed atrial fib, the difference between the ones that had virtually no omega-3s versus the ones that had the higher levels was a 30% difference. So do you do any, or do we do any of that testing for either omega index or omega-3 plasma levels?
Yeah. Okay.
No.
No. Again, there's, you know, see, atrial fib is common. Canadian Cardiovascular Society comes out with guidelines, and a bunch of smart people get together in a room and decide, hey, what should we do when we see someone with atrial fib? And there's a set of things that say, hey, this makes sense to do. You know, you should do probably an echo and you look for valves and heart pump. You should do a thyroid test. You should, you know, check their hemoglobin. You know, you should think about at least asking about sleep apnea, in some cases testing people. You should be doing some blood pressure monitoring. We aren't, unfortunately, we all kind of want to know why. And I sort of talked to you about the various causes, including high blood pressure, lifestyle, you know, alcohol, valve disease, all these things. But for many patients, the answer is we don't know. And we all kind of struggle, and we want to find why. In some cases with medicine, atrial fib is one of those things, is we just don't understand it. Why did that person hip wear out faster than the rest of them? Why did their knee wear out? Why do you get atrial fib? And that's what's frustrating for atrial fib, is that often we don't have the why. Certainly that's where it's important that we have universities and smart guys like this that are doing research to help us with the whys, and maybe we'll find something that is more, that, you know, that by finding some factor and manipulating some factor, we're going to help prevent atrial fib. But for the time being, you know, I think a lot of the focus, certainly the biggest prevention, as opposed to, you know, I must admit, Paul, I'll tell you, I have patients who ask about vitamins. I say, hey, you know, probably find a vitamin store that's 2 kilometers away, walk there every day and get one and come home. I don't care, you know, which, I'm not so fussed about which one you get. So I think, you know, because certainly, I mean, the obesity epidemic that's happening in North America is probably the biggest factor that's going to fuel atrial fib, because obesity leads to hypertension, high blood pressure leads to sleep apnea, leads to more atrial fib. So if we can do anything to prevent atrial fib, in my mindset, it's do what we can do, you know, change our portion sizes and get active and do everything we can to kind of keep on.
Can I add?
Yeah.
From a more personal level, I think for me, having lived with it now for 4.5 years, there's a level of acceptance for me that's had to happen around, you know, I can't control it. So like I can control things that I do to kind of live my best life, right? But I can't control that when I get an episode. So it's the acceptance piece has been big for me over the last little while. And there's a lot of days where it's going, oh my God, I don't want to accept this anymore because I just want to, you know, do what I used to do. So, and you know, practicing some of the things that are emotionally and mentally available to me to, like in terms of self-care. And you know, we can try to understand what triggers. I don't know, I can't even figure out what triggers my episodes anymore. I have a glass of wine, I have an episode. A week later I have one, nothing happens. Or, you know, any of those kinds of things, and they just happen. So I just wanted to add that.
Yeah, that's a really interesting thing to bring up, and we'll come back to the omegas in a sec. But
I love your thoughts. Yeah.
Okay. Well, I'll just say a quick thing about the omega-3s and 6s, and so not to make a blanket judgment about this, except to make a blanket judgment about this. So when it comes to the treatment of atrial fibrillation, like many cardiovascular conditions, you know, practices vary, but generally speaking, our philosophy is that we're going to do things when we have high quality evidence to show that doing the thing produces the result that we wish. In other words, it's effective and that it's safe enough to do the thing. And so just where we're at with omega 3 and 6 and supplementation, in other words, doing something about something we might find, say, a low level of based on a blood test, we're generally not going to do that blood test until we have some evidence that doing something about finding, say, a low level, like taking a supplement, does something beneficial. And when it comes to AFib and omegas, we don't have anything like that right now. The blanket statement is that when it comes to preventing cardiovascular conditions in general, there have been a multitude of very large randomized controlled trials, the best kinds of studies that we have, about the different variants of omega fatty acids. And as far as all of those studies show, they have neither a beneficial nor harmful effect. So that's a reason why you're going to tend to not see a lot of enthusiasm from cardiovascular people or other people involved in treating patients for those. They don't appear to be beneficial from a cardiovascular point of view. Just wanted to prompt based on something that you were talking about there, Cheryl. Who here feels like they have a sense as to what triggers their AFib? Does anyone feel like they have a sense of that? Okay, almost nobody. Not nobody, but almost nobody. Okay. It's a really interesting and strange topic, and I love that you shared some of your thoughts about that, but it's very enticing for all of the reasons of wanting to feel like one has a sense of control over this. And the whole dimension of that and your feelings about AFib is very important and something that we need to focus more on as care providers and more on as researchers to help to better do that, because just the idea of the lack of control, as you know, many of you know, produces anxiety, and anxiety can fuel, you know, the elevated heart rate. And I'm not saying that causes AFib, but you're familiar with the cycle. Anyway, okay, well, almost here nobody is very attached to the idea of triggers. So I'll just say that there's a really cool recent study that showed that that's probably appropriate, and that when you study groups of people that have what they think are triggers, they're really sure that if they sleep on their right side, that they won't have AFib, and if they sleep on their left side, they will. Or they're really sure that coffee causes AFib in them. This is a classic. And that certain diet, if I eat a certain meal, I'm going to get AFib. Okay? This is common to have these, I'm going to call them attachments, because they're really positively reinforcing things. It only has to happen once or twice where you do or don't do a thing and then do or don't have an episode, and now that's a fixed belief. Anyway, really cool recent study. These studies are super hard to do. Almost all of those beliefs are myths, and that almost every trigger that you might name that you're attached to, and none of you here really are, is probably not actually a trigger for your AFib, and there's only one exception, and that's alcohol consumption. That one is very strongly connected to triggering episodes of AFib. All of the other ones, including coffee, are not. Stress wasn't studied here because you could only study things where people could purposely expose themselves to the thing or not. And I guess you could, you know, do your taxes or something and purposely expose yourself and then not do your taxes and see how much more stressful. Anyway, that wasn't really studied, so I'm not applying it to that.
Yeah, certainly the alcohol is definitely, there's actually such a term called holiday heart, and we do see people that are, hardly imbibe, and the twice a year they get atrial fib, or those that do imbibe regularly and they suddenly give it on the weekend, they go to Vegas. Certainly it is something that is lifestyle-wise probably the biggest thing you can do, and if you show up and you want ablation and you're drinking 20 units a week, guess what, you're going home.
Hello. I just want to thank the panel too. Tonight was super informative. My question is, I guess, about seeking medical attention. If you're maybe in the early stages of an AFib diagnosis or what have you, if the attack is violent and extreme, is there a time when you should seek medical attention or go to the hospital? I'm talking about going from 50 beats a minute to 175, back down to 85, back up to 200, and it lasts for hours.
And how do you feel? That's the important question. How do you feel?
Scared. 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 I guess with me personally, I know we're not talking about individuals, just individual stuff. I don't want to have a stroke. Chest pain or shortness of breath? Scared. Shortness of breath would come with it, and you're just very fearful. And worried about when or if this stroke would happen, and not on blood thinners yet either. So I heard someone say if you were on blood thinners, you really didn't have to worry about the stroke as much, but if you're not on those yet.
So you're the type that really ideally
intermittent
should have a physician go over your action plan. The fact that you're not on blood thinners, not in the early stages, you're the ideal person where someone needs to sit down and look at your individuals and say, here's your plan. If you're on blood thinners, you're on some drugs that are going to slow the rate, and you're feeling pretty good, and you don't get that symptomatic, a plan's kind of not as important. But you're the sort of person where a plan is very important, and we couldn't individualize that as panelists. That's a job for a doc, and and pharmacist, and whoever your AFib people are that.
So if we do have a plan, which we do have a plan, my question would be, I guess, how long would one wait with those type of symptoms before seeking medical attention? Would it be the 24 hours if it was doing that extreme heart rate for that long, for hours?
Okay, well, so it used to be the guidelines were if you came in an atrial fib and you've been there less than 48 hours, we could boom away. We could shock the heart back in sync. Now the guidelines have changed, they've been a little tighter. Is now 24 hours. If you've been in for over 24 hours, you probably won't be getting a cardioversion, because now there's a risk that if we do the paddles, we could shake loose a clot that's formed in that last day or so. So in fact, some patients like yourself, we actually not only have a pill in the pocket approach for the rate, we will sometimes have a pill in the pocket approach for blood thinners. So I've got a few patients like yourself that have very rare atrial fib, but they have a pocket of blood thinners, and if they go to Mexico and end up in atrial fib, they might actually pop an anticoagulant and kind of get on it so that they don't. It gets complicated if you're not on blood thinners and you've been there for more than 48 hours. So again, I think we should kind of not individualize too much and not give too much personal advice, but it's something. I think both anticoagulants and.
That's why I just kind of wondered kind of where that cutoff period might
typically,
be. Where you get scared.
For patients not on anticoagulants, I would say 24 hours is the maximum you should be in atrial fib.
Okay, thank you.
Hello. I'm wondering why there isn't an EP study on the atrium before an ablation procedure.
Yeah, so I'll talk about what an EP study is. So we all kind of know, or some of you may know what an angiogram is. That's where we stick catheters up to the side of the heart and we squirt dye down the arteries. You look at the plumbing. You kind of see whether you got blockages. Well, there's a similar procedure where you stick catheters up inside the heart and kind of check out the electricity. It is a very important study for some people who have conditions that are different than atrial fib. There's some conditions where people have accessory pathways that are easily to ablate, and so we will do EP studies in some patients. Some patients with ventricular studies will do VT studies, but EP studies. But electrical mapping study in atrial fib isn't particularly helpful. It doesn't really changes the treatment. It's if you're going to go in there, you're going to go in and kind of just make a whole bunch of burns or not. So it's rare. There'd be the exception. There'd be the odd patient who has atrial fib, say in their 30s or 40s, where we think the atrial fib is a secondary phenomenon. We think there's some other arrhythmia that's happening first, and then they're ending up in atrial fib. So there's the odd patient that does get an EP study before an ablation, but most cases they're kind of going directly in with an intent to make some burns or some freezes and not doing a complicated mapping procedure. It's a little different than an angiogram where you'd always take the map before you start stenting away. Yeah.
It doesn't change anything.
Yeah.
I think we've got time for one more question before some concluding thoughts, Kathy.
Good evening. I just had a question regarding the sleep apnea and how that comes into play, and I've never heard of the dental device. So if I can get some clarity on that.
Ryan, you want to take? Or no, either.
Well, just in a nutshell, sleep apnea is now pretty well understood to be a risk factor for atrial fibrillation. That doesn't mean it causes atrial fibrillation. It's these relationships are a bit more tenuous than that, but it's now pretty clear that it's a risk factor for atrial fibrillation. What we don't have clear evidence of is that treating sleep apnea, like with CPAP, and we can talk about the other methods, we don't have clear evidence that treating it prevents AFib or that treating it helps patients' AFib symptoms much. That evidence may come. So we usually treat sleep apnea, and these guys can talk more about how and why, for its own sake, as opposed to for any particular atrial fib reason.
Yeah, Cheryl. Yeah.
I just saw Dr. Baraki, is that? Yeah, the electrophysiologist around that, and he indicated to me, this is for an assessment for the ablation, and he recommended and strongly suggested I look into that for more positive outcomes for the ablation that I'm on a wait list for.
Yeah, so this is sleep apnea is a disease that is highly variable, again, in kind of what people experience and what physicians think about it. So sleep apnea is when someone stops breathing in the middle of the night and they just kind of, and then nothing happens for a while, and that puts the heart at stress. Your blood pressure goes up, your oxygen levels drop, the heart gets stressed out, and there are people that get atrial fib in the middle of the night. If someone comes in and says they only get atrial fib in the middle of the night and they happen to be 360 pounds and they have a big wide neck and they're drinking 3 scotches before they go to bed every night, then we probably think that's sleep apnea. Now, in some cases, we will manage that with a sleep apnea machine.
Or 2 scotches.
And some people can manage their sleep apnea with weight loss and lifestyle change. There have been large studies looking at the effect of sleep apnea on mortality and morbidity, where they gave people with cardiac disease, basic cardiac disease and strokes, large studies, 7 years, where half of them got CPAP and half of them got kind of a sham machine that made a bunch of noise and didn't deliver CPAP. And in fact, it didn't show a difference in outcomes, heart outcomes. It didn't show a difference in strokes, heart attacks, or death. So for most people, sleep apnea is about quality of life. If you grab a machine and you feel like a new person, you can tolerate it, you stay with it. If it doesn't make much difference in your quality of life and you feel horrible with it, then you seek other things. But certainly the one study that really has shown some evidence is that patients who do get it ablated, if you don't treat the sleep apnea, your ablation success goes from 70% down to much lower. So we are more aggressive in sleep apnea testing and treatment in patients that are heading towards ablation, which are usually those patients that are highly symptomatic and other things aren't working.
You asked specifically about dental.
Yeah, she had mentioned that a dental device versus having the big machines all the time.
There's some people that's part of the obstructive sleep apnea is obstructing. So in some cases, one procedure, they used to go and cut out your little thing that dangles down from the back of your throat that you see, it's called the uvula. In some cases, they'll go and cut that out, and actually big surgical procedure where you take out part of the palate and and take out the uvula. That's become not really much of favor. And the dentist, again, sleep apnea, I'm going to be a little bit biased here, has become a little bit of a gig. It's a little bit more privatized than the rest of medicine. And, you know, there's people, you know, there's a lot of diagnosis going on and probably a lot of therapy. In some cases, it may be more therapy than some people need, but certainly if you're symptomatic, fatigue, falling asleep in the middle of the day, you've been told you have moderate to severe sleep apnea, and the machines aren't working, then some patients do get a device that basically prevents you from, you know, obstructing in the middle of the night, kind of keeping the mouth open. And again, some patients can tolerate that when they can't tolerate a machine. So there are dentists that do work in sleep apnea. Some patients do derive success, but it's not one size fits all thing. It's a, you know, trial and error like some other, like the medications are for atrial fib.
So maybe, thank you for those wonderful questions. And we don't have time for any more, do we, Lindsay, at this point in time, unfortunately? So any outstanding questions, maybe you can grab the panelists on their way out. But maybe for now, we wanted each of the panelists to just kind of have some closing thoughts. So we'll end with that. And oh, you've got. Okay, well, we'll leave that one between the two of you.
Yeah, I don't want to be the take your medications guy. Well, yeah, okay. Yeah, this is my main thought. So clearly, as we've all discovered here tonight, if for any of us who weren't already aware, this condition has many, many dimensions. Kevin, you started us on that journey at the beginning. Many, many dimensions, many aspects. We haven't even touched on all of them here. But with my biases fully on the table, avoiding the most devastating outcome of atrial fibrillation means avoiding having a stroke. And I'll just reiterate, there are no treatments that we have for almost anything in medicine that are as effective as those blood thinners, those oral anticoagulants for preventing stroke in AFib. I'm not exaggerating there at all. And it turns out it really does matter when you miss doses. And it especially matters when you miss doses of the newer ones, the apixabans and dabigatrans and rivaroxabans and edoxabans of the world. So if you're prescribed those medications through any way you possibly can, take them exactly as prescribed. And if you're doing that, tell your friends and family who are also prescribed them to do the same for the same reasons that you are. Okay, I was that guy, but I tried to provide some evidence for why I'm saying that other than just than for you to just trust me.
Yeah, I'm just so happy that you are here. And I think, like, part of self-care, the biggest piece is, like, from the research that patients don't engage in self-care comes from a lack of knowledge and not understanding why they're taking their medications. So if you don't understand why and like you've learned all about the stroke risk tonight, I'm sure that will help you think a little bit more about taking your medications. And so the fact that you're here, that's an amazing step for building a positive life living with atrial fibrillation. And I just wanted to say that out of all the research that I looked at with that systematic review, those that engaged in like all three elements of the self-care, so just taking your meds, but then drinking 3 scotches before bed and overeating and doing all the other things. Don't do those things. Yes, that's don't do them, or
oh, I thought you were going taking your meds.
Yeah, and then drinking scotch. Yes.
Overeating.
Yes, but if you're just doing the one thing but not doing the other pieces, you're not going to get the same benefit. So really just as best you can, I know it's hard, but engage in those things that really are going to help maintain your health. Like Kevin said, it's not as much taking the vitamins as getting some exercise and getting out and walking and controlling, like if you're smoking, not doing that, and if you're drinking, then not doing those things. So those maintenance pieces, understanding how to take your pulse if you don't know how. There's many neat apps out there that can actually show you what your pulse is just by using the camera on your phone. And then getting a management plan that will help you not go to the emerge unnecessarily, or that will help your anxiety if you know that you have a plan in place. So yeah, I really commend everyone for being here. You're on the right track and the right step moving forward by just getting as much knowledge as possible.
Thank you. I guess my final thoughts would be around probably my psyche. And probably, like, I look at my life now and have for a long time as a big circle with different quadrants. And, you know, I need to attend to certain quadrants. There's the physical, the mental, the emotional, the social, and the spiritual. I like to include the spiritual because I think that's where it helps me to stay away from the unknowns, that I have no control, and what do I have control over. And, you know, so it's kind of, you know, it's not all in, you know, sync at all times, but that's kind of my whole experience as life. And I like to do things that I enjoy now, and, you know, that I stay active. I keep getting told staying active strengthens your heart or keeps it strong. Right? No matter what you do, whether it's a walk. I even have found, like, in an episode, I'll just go for a walk, and then I find out my episode stops without taking extra bisoprolol or whatever, right? So it is kind of that whole piece of self-care, and yeah, I wish you all well on your journey in this disease.
Yeah. Thanks.
Thanks
once again for everybody coming tonight, and I think just to reiterate that this is atrial fib is a journey, and I think as cardiologists and as physicians, GPs, and as other healthcare practitioners, now we have atrial fib nurse practitioners, we have certainly, you know, pharmacists, lots of people as part of the team now to manage atrial fib. We kind of used to think of this as almost a bit of a nuisance thing because we didn't really have too much to do. We gave patients digoxin, which is an extract from a flower, a foxglove plant, and we couldn't do much more. There's been studies that looked at atrial fib and the impact on people's life, and shows that as cardiologists, we get, you know, someone's had a heart attack, that's a big deal. They've blocked an artery, they've lost their heart function to some degree. There's studies that show that the diagnosis of atrial fib on people has pretty much the same psychologic impact as the diagnosis of someone who's diagnosed with coronary disease and a heart attack. And I think it took a little while to realize that the impact on quality of life is important. And fortunately, atrial fib has been a focus of an awful lot of research over the years. We recognize that it's a journey, that every patient's journey is different. Some people will be very bumpy, other people will have a nice smooth journey. One thing I have noticed as a final note, typically the patients I've had, as life slows down, your body slows down, and the rest of you kind of gets older, usually the atrial fib tends to become less of a nuisance. It seems that there seems to be periods in people's life where it bugs them an awful lot, and there's some people that we go through 5 years of juggling this, juggling that, changing this, doing that, their emergency procedures, and then they show up in their office 5 years later, they're in atrial fibrillation, they're on blood thinners, the rate is controlled, and they're saying, hey, things are pretty good, but my knees are slowing me down, I can't play pickleball, but you know, my atrial fib's really not my problem anymore. So I think the one thing is that the atrial fib journey can be quite variable, but it typically does become less symptomatic as people slow down. For some people, that's a good thing. For people that want to be, you know, active in skiing and playing pickleball on their 95th birthday, it becomes a bigger issue. But for a lot of people, things do simmer down. So there's a bit of a light at the end, you know, light, you know, going forward that eventually we can through various maneuvers help people out so their journey doesn't end with a lot of grief.
Great. Well, let's give them a hand. So I do want to just echo everyone. Thank you. I have nothing else to say except what an awesome panel and what an awesome audience. You have made it a very, very enjoyable and lively event, and we wish you well on your AFib life and journeys, as everyone else has said. So just one reminder before you go, though, on your tables are evaluation forms, and we would welcome your input, your feedback on the session for our future planning. So have a lovely evening, and we hope to see you again at some of these events.